Right. So we are going to deal with geriatric medicine. All right. Geriatric medicine. So what's about the specialty? This is a very interesting specialty, and the Royal College of Physicians have a diploma for geriatrics. If you're interested in geriatrics, you can actually do a diploma in geriatrics. Old age people have myriad and multitude of problems. It's not just one or two problems they have a multitude of problems. So it's near to impossible to sit here at this one place, and if we think we are going to learn all the problems of old age people, never going to happen. All right. And you cannot treat all the problems of old age people at once. If you try to do that, if you try to attempt that, you will end up in something called polypharmacy. All right. You will end up in something called polypharmacy. So I'm just going to, what we are going to do in this lecture, we are going to brush up some common stuff in old age people for just 10 to 15 minutes, max 10 minutes. Then for around 40 to 50 minutes, we are going to do some MCQs. All right, we are going to work together. Happily, we will do. All right, then 10 minutes. I am here to answer your doubts, all your queries. All right, all your queries. I am ready to answer because I am getting such queries only. Somebody's diploma is not received. He sent me around 4 or 5 messages after calling RCP. What is the diploma? We don't know. DHL flight where they dropped in midway in some ocean. We don't know. Okay, so some common geriatric conditions and the management. So this is the geriatric care in UK. All right. The patient care is not just in the hospital. They have the care home. Okay, they have a rehabilitation wards. They have a community hospital. They have a medical receiving ward. They have outpatient services. See, as people age in the United Kingdom and in Western countries, they don't age many times. Sadly, though their life expectancy is high, they don't live in a family environment, right? Like how we are. You see your grandfather is with your grandmother. That you won't find. By the time somebody is a father, wife may be out running away, then there will be stepmother, one stepmother, two, then grand stepmother, blah blah blah. It goes, and many times people end up feeling lonely. That's why they are hiring a lot of people from Asian countries as caregivers for elderly. You won't see that much in Asian countries, because we have a family setup where they don't have, the families are broken. All right, now they are coming back to a proper setup where they want long standing marriage, where they can support each other. Now they come to realization, till this 20 to 40 you can dance whatever you want. As you age, you need a companion. Above all, you need your creator. All right, so that's the geriatric thing. So what are the common problems in elderly? One of the most common problems is falls. Okay, so what are the causes of falls in elderly? Okay, I'll just draw and show you. If this is an elderly gentleman, how to easily remember what are the causes of falls? I'm just going to draw an elderly gentleman. Please don't get scared of my drawing. This is his eyes. This is his nose, mouth, ears. What are the most common causes of falls? Because so many MCQs will be based on falls and memory loss. Okay, so what are the causes of falls? In the head, it can be a stroke, it can be a seizure, it can be a transient ischemic attack. Ear is an organ responsible for your balance and equilibrium. All right, any vestibular disorders like that of your BPPV, your Meniere's disease can cause falls. In the mouth, just do remember one thing, very, very, very important cause of falls in elderly is polypharmacy. All right, remember one more cause at the level of MRCP part 1. For paces, there are multitude of more causes. Remember, here is his heart. What can happen to his heart? Arrhythmia, cardiac syncope. All right. So then in the knee, any joint instability. Then in the legs, any peripheral neuropathy. Also, don't forget autonomic neuropathy. These are some of the causes of falls. And among the causes, the drugs are very, very important. Okay, any time an elderly patient is having more than 4 drugs, they are tend to have some falls. Most common drugs, as per Oxford, is benzodiazepine, your antidepressants, your antipsychotics, your opiates, diuretics, antihypertensives, antiarrhythmics, anticonvulsants, all these drugs. All right. So the next thing, this fall can be either due to a syncope or a seizure. How do you identify whether it's a syncope or a seizure? There are certain things. A syncope will have some underlying disease like a heart disease, or it can be a vasovagal syncope, or it can be due to drug induced seizures. There can be past history, or there cannot be. Even an electrolyte imbalance can cause seizure. All right. And I want to ask you all a question. Somebody is presenting with a seizure. He has been brought after an episode of seizure straight from the ambulance. Okay, what is the very first investigation you will do? Very first test immediately as soon as you are receiving, you are getting a handover. What's the very first test you are going to do, doctors? Come on. Who's going to answer me? Quickly. Quickly answer because it's an MCQ. Very first test immediately you will do as soon as you get the patient. Airway management is not an investigation. ECG, you will do only the patient after coming into the ward. Very first thing, immediately, what you have to do? Very first thing, come on, all of you are working in the hospitals, and I believe you will be knowing. The very first investigation, immediately, yes, blood glucose levels. Blood glucose levels. Of course, pulse, everything vitals they would have measured. Blood glucose levels. Very first thing you need to know. All right. Then is the syncope can be associated with some situations like a heat or prolonged standing, meals, anything, but seizures typically won't. And syncope can have some nausea, sweating, lightheadedness, or sometimes a chest pain or palpitations, but a seizure and aura can be there, like in a temporal lobe epilepsy. All right. During the event, typically a syncope patient often goes pale, sweaty, or absent, or any weak cardiac pulse. Here in seizure, there can be raised muscle tones and contractions and everything will be there. After the event, there can be weakness in case of a seizures. It's which one we call it as a torch palsy. And remember, tongue biting is possible on both sides. Incontinence is also possible here. All right. And test when it comes to syncope, there can be abnormal ECG. Here, there will be abnormal EEG for seizures. Just remember this. And these are some of the target INR values in elderly. If you want, take a picture of it. Only in elderly, okay? Elderly. In atrial fibrillation, classical target 2.5. Venous thromboembolism, again 2.5. Recurrent venous thromboembolism, again 3.5. Mechanical prosthetic valve, heart valves, like, again 3.5. All right, these are some of the basics. I don't want to go into the basics because all these conditions you will be definitely being taught by mentors over there in your med exam expert. Okay, neurology, if possible, I will come and teach you a couple of things. All right, so we are going to work out some MCQs and learn from the MCQs. The very first question: an elderly woman feels that some people are trying to kill her. She believes that she can see them hiding as she walks to her apartment. Mental status examination is revealing she has severe anxiety, markedly impaired recent memory. She has history of hypertension and atrial fibrillation. Which of the following symptom is suggestive of cognitive disorder? The question is simple. Which of the following symptom is going to suggestive of cognitive disorder? Let us see. A visual hallucination, severe anxiety, significant memory loss, olfactory hallucination, elaborate delusion. Which of the following? Come on, all of you try to answer. Don't shy away. Make mistakes. It's okay to make mistakes. We learn from our mistakes. Hey, visual hallucinations. Okay. What is the question? I'll write the question. Which of the following suggests cognitive disorder? That is a question. Come on. One more person answer, then we will discuss. What is mean by the word cognition? Cognition. He has some cognitive deficit. What is mean by that? What is mean by cognition? Cognition is somebody goes, sits, listens to something, takes the information, process the information, and apply appropriate judgment and act accordingly. Am I right? That's called cognition. So what involves in this? It's nothing other than your memory. It's nothing other than your memory. So somebody with the cognitive disorder, you want that person should have significant memory loss. What is the thing bedside? Immediately they will do. They will do something called AMTS, abbreviated mental test course. All right. Of course, we can also do MMSC, but AMTS is much more quicker than MMSC. We do AMTS. I'm from Glasgow, where the coma scale itself has been invented. All right. So we do AMTS quickly. What are the questions we will ask immediately? Somebody is coming with a confusion. Hello, sir. What is your name? May I know where you are now? May I know what you ate in the morning? Do you remember your birthday? Do you remember your wedding day? Do you know who is the prime minister of this country right now? You have to ask. So the answer is memory loss. Very important. Yes, Dr. Osama, time, place, and person. So empty a score quickly we will do. Why? To check the memory is the first thing you are worried about. Then comes anything else. He has hallucination, he has delusion, whatever it is, then comes anything else later. Okay? Memory is the first thing you are going to be worried about. So the answer is significant memory loss and nothing else. All right? Significant memory loss. Next question. All right, let us work out this question. 82-year-old man is hospitalized after experiencing racing thoughts, insomnia, increased impulsivity, and grandiosity. So, what is he having? First, tell me the diagnosis. First, tell me what is he having? Racing of thoughts. Have you seen what is racing of thought? Racing of thoughts? You know, racing of heart. What is racing of thought? Suddenly, the thought will change from one thought to the other thought. For example, Dr. Osama is there, Dr. Abhishek is there. I'll be talking to them about something. All of a sudden, Doctor, whose mic is turned on? Please, somebody please turn up. Somebody please turn off the microphone. Whose microphone is on? Please turn off the microphones, doctor. I'll be really happy if you do that, okay? All right. What is racing of thoughts? All of a sudden, my thought will shift from one to other. Suddenly, I'll be talking, yes, Dr. Osama, we'll be going around in the evening to have some cool grilled chicken and biryani. Then suddenly, all of a sudden, I will tell, no, we will now go to shopping. Then we will go to beach. He will be confused. What on earth this guy is even talking about? Is he lost his senses? So that is called racing of thoughts. And insomnia, this particular people will have a decreased need for sleep. That is one of the dangerous thing. Decreased need for sleep. Even if you ask them to go to sleep, they won't sleep. Have you seen elderly people walking around at night and delusion of grandiosity, telling that I am this, I am that, you know about me, you know about my background, you know about my power, you don't know anything about me. That's called delusion of grandiosity. So all these three, four things together is called your mania. This mania is a part of bipolar disorder. All right. So now what is the problem? They have given lithium. It is in the appropriate level, even more. So what is the next drug you will give? If lithium is not responding for a bipolar disorder, what is the next drug you will give? I don't want any one of you to see any options and give me the answer so that it will be great. Come on. 10, 9, 8, 7. Excellent, excellent, excellent. Dr. Abhishek and Dr. Ross, you're beautiful. Valprovate. Give a trial of Valprovate. All right. Give a trial of valproate. Got it? All of you. Lithium, if not working, then valproate. Then if it's still not there, call your psychiatrist. 81-year-old man with a 20-year history of type 2 diabetes. He visits the general practitioner, okay, for a routine checkup. Okay, throughout the check for diabetes mellitus, discovers peripheral and autonomic neuropathy. The man comments at times he feels he is short of breath on exertion and also has some ankle swelling. GP does an electrocardiogram. It shows left bundle branch block. What could be the cause? 81-year-old male, shortness of breath, left bundle branch block, shortness of breath. Oh, sorry, I already written ankle swelling. What is the cause? Simple scenario, doctors. Like this is some patient you will be getting day to day in your life. Am I right? Is there anything A, B, C, D, E? Is it mitral stenosis? Absolutely not. Why? There should be some diastolic murmur, and mitral stenosis EKG is entirely different. That will be taught to you by your mentors and your directors in med exam expert. Okay. Is it pericarditis? What is the ECG finding in pericarditis? We will discuss all the negative options also. Come on, we will discuss. What are the ECG finding in pericarditis? What is the ECG finding in pericarditis? All of you going to learn now. Okay. It's just the ST segment elevation. What's the most specific finding? Yes, PR depression. Most specific. Of course, ST segment elevation, everything will PR depression. It's the most specific finding. Very good, very good. All right. So, what is the ECG finding in pulmonary embolism? What is the ECG finding in pulmonary embolism? Very good. S1Q3T3 pattern. This is called your McGinn White pattern. It's called your McGinn White pattern. Am I right? Coming to tricuspid stenosis, what kind of murmur you will get? So the answer is what? Ischemic heart disease. It's ischemic heart disease. He is proceeding for heart failure. All right. Is proceeding for heart failure. All right. Clear. Next question. 76-year-old man has severe depression with psychotic ideas. He has been an inpatient for a psychiatric ward for 3 months. He had two different antidepressants. Adequate doses for adequate period. His mood had continued to deteriorate in spite of having the antidepressant. Now he is refusing to eat. He says his food is poisoned. Drinking only minimal fluids. He is becoming dehydrated. What is the problem here? Of course, he is having severe agitated depression. This is called agitated depression. All right. He is having agitated depression. Okay, this is not psychosis. This is called as agitated depression more often. Psychosis, it's a type of psychosis. It's an agitated depression. Depression can be two types. One set of people, if you notice, if they depress, they will go to some corner, they will sit, they won't talk to anyone, they won't speak to anyone, they won't interact with anyone, they won't mingle with anyone, they just hate the whole world. They just want to be left alone. That's one way of somebody is depressed. The other way of somebody can be depressed is they can be agitated. They will think everybody around them is evil. Everybody is doing some harm to them. This guy is doing something nasty. That guy is doing something nasty. That's called agitated depression. All right. So he is now at the risk of what? Just read the scenario. He's not eating. He's not drinking. So he's at the risk of what? What he is at risk of? Come on. I want all of you to interact. Come on. Talk to me in the chat. I'll be more than happy. Suicide. What is it? He's at the risk of dehydration. Very good. Also malnutrition. That's weight loss. Malnutrition. So what will you do, doctor, to this patient? Logically tell me, what will you do? Leave the options. Let us think beyond options. Then once you see the option, you will easily get through. IV fluids. He is refusing to do anything. He feels the food itself is poisoned. What IV fluids you will do? If you go and take a needle close to him, he will think you are going to give some poison to him and to kill him. Very good. The treatment is ECT to such patients. The treatment is ECT. What is ECT? What is ECT, doctors? It's called electroconvulsive therapy. The reason is any of the medication if you are going to take, he is going to plainly refuse. He is going to plainly refuse. Okay, so he is going to refuse no matter what kind of treatment you are going to give. Only way they will do is they'll put him on a midas or haloperidol, restrain him, give an ECT, because that ECT will somewhat help in resetting his depression. It works effectively. Of course, you know, if you see in other, I mean, like, especially seen in movies and all, it's shown in a very kind of, negative vibe. ECT, people getting tied up, given something in between the mouth and powerfully doing that, or some kind of torture method. So, where you will get DCT? What are the indications for ECT? I'm going to tell you the latest indications of ECT. Okay, first, major depression. This depression, when it is resistant to more than two drugs, where there is a need for a rapid response. What is a rapid response? For example, somebody is absolutely suicidal, or somebody is not eating and not drinking, and that lady is pregnant. There is a food and nutritional need of fetus. You have to go ahead. All right, somebody with again refusal of food at the risk of dehydration. That's another criteria. Somebody with severe medical comorbidities, and somebody have a previous response to ECT. Somebody with catatonia, very good. All right, some psychotic features. All these are indications. Okay, all these are indications for ECT. Very, very important. So the answer is ECT. Next question. Yes, let's discuss the next question. Okay. All right. 75-year-old man. Okay. Remember 75, 6-month history of weight loss. On examination, he has edema. What's happening here? Okay. He has a creatinine of 380, albumin of 22, urea of 13. And he also has lumbar back pain. And urine dipstick shows proteinuria. It's more than enough. X-ray shows lytic lesion. What is the diagnosis? Back pain, protein in urine, lytic lesion in X-ray, not CKD. What is it called? Come on, what is it called? And non-prostate. All right. Prostate metastasis may present like that, but not with proteinuria. All right. This is multiple myeloma, not diabetic nephropathy. This is multiple myeloma. Come in everything. And also what? Which a renal biopsy performed shows positive for Congo red staining. Congo red staining positivity shows amyloidosis, which is again a characteristic feature of multiple myeloma. This gentleman has multiple myeloma. But the question is not that. What they are asking, which of the following you would expect to find in his blood test? A, B, C, D, E. What you will find, doctors, quickly? We will go to the next question after this. Come on, what you will find in his blood test? All of you can answer. Fantastic. Paraprotein. your BJP protein, Benz Jones protein, and a lot of other paraproteins are there. This is a type of paraproteinemia. You won't find hypocalcemia, rather, you will find hypercalcemia. You won't find polycythemia, rather, you will find anemia. Positive ANA is non-specific. Positive HIV test has nothing to do with that. In an 80-year-old man, he's not going to go out around and have fun. Excellent. All right. Next question. 70-year-old man brought to the outpatient clinic by his son. His son complains father's personality has changed. At worst, he is drowsy and unresponsive. He claimed to see things that aren't near really there. What is it called? He is having visual hallucination. Am I right? All right. That means he's seeing something which is not there. It's called visual hallucination. All right. Over the past few weeks, he also has been tripping a lot on the carpet, is no longer safe on the stairs. A patient's small dose of neuroleptics, which made things million times worse. He has a expressionless face, mild resting tremor, mini mental examination is low. So Parkinson's future plus dementia plus what is there, doctors? Visual hallucination. What is it called? Very good. It's called Lewy body dementia or dementia with Lewy body. However you want to call it, it's a type of Parkinson plus syndrome. We call P plus. So now that's not the question. The question is, what is the most likely primary brain pathology? Lewy bodies, multi-infarct, neurofibrillary tangles, normal brain Pick's bodies. Will it be a normal brain? Absolutely not. Multiple infarct you will find in multi-infarct dementia. Everything we are going to learn. Neurofibrillary tangles, where you'll find? Very good, Alzheimer's disease. Pick's body is where you will find, doctor. We should learn all the other options so that next time if the option is little twisted, you won't get scared. Where you will find Pick's bodies? Pick's disease. All right. But you will find here Lewy bodies. What are the specialty of Lewy bodies? Lewy bodies, remember SCE. All of you know there is something called SCE examination in MRCP-uk, Specialty Certificate Examination. All right. What is SCE? Spherical, because they may not give Lewy bodies. Sometimes they will give this description. So learn to know that the other way around. Spherical, cytoplasmic, eosinophilic. These are the three characters. What are they? Spherical, cytoplasmic, eosinophilic inclusion bodies. These are called your Lewy bodies. These are called your Lewy bodies. All right? These are Lewy bodies. Now, which of the following, leave everything up is a story. This is the MCQ. Which of the following clinical feature would favor an acute organic reaction, that is a delirium, over a dementia? What says it's a delirium? It's not a dementia. Everything. Go through that options. First is apathy, disorientation in time, flat affect. All right, flat affect. What is apathy? What is apathy, doctor? Apathy means lack of motivation and interest. Sometimes we become apathetic towards MRCP preparation because we lack motivation, we lack interest. Or will they be disoriented with time? What happens? What happens? Anyone? What is the answer? How do you differentiate a delirium with the dementia? Yes. What are the differentiating factor between delirium and dementia? Right, remember, it's a fluctuating level of consciousness. I'll tell you some of the important points. Note down. First, delirium is more acute. Dementia is more progressive. All right. Well, some of the deliriums can be reversible. Reversing dementia is kind of rare. It's not that going to be possible. Here, everything fluctuates. Here, it's more progressive again. All right. Attention, if you take attention, is impaired in both. All right. It is impaired in both. Here, if you see the speech, number 5, if you see speech, the speech of a delirious person will be incoherent. Where the dementia people, what will be the problem, do you know? They will have something called word finding difficulty. What is word finding difficulty? If Dr. Osama Abdullah is right in front of me, if he is a colleague of mine for last 20 years, we know during our school days, undergraduation, post-graduation, super specialty and sub-super specialty fellowship, everything, still in 30 years of time, if I see him, I'll be like, who's this? Who's this? Who's this? I won't be able to identify this gentleman. Whereas I would have been his friend for nearly 30, 40 years, traveled together, had meals together, had a lot of good time together as friends, but I will forget completely. His name I won't be able to pronounce. That's called word finding difficulty. Very sad state. I've seen parents unable to identify their own children, seeing children breaking down to tears, seeing that kind of pathetic state. It's very sad state, very sad state. All right. So these are the differences. I hope all of you got. Fluctuating level of consciousness is a characteristic feature of your delirium. All right, your delirium. Next question. Just leave this question. We'll go to this question. This is very important question. Okay. 75-year-old women comes with transient ischemic attack and most recently a stroke with permanent disability involving weakness and poor coordination affecting left side of the body. She has a issue and she is on ramipril and she is on indapamide. All right, and past medical history on examination, BP is around 155. There is a right carotid brew. Right carotid brew is there. Yeah, right carotid brew is there. So now what is the question? Let's go ahead. Her hemoglobin, WBC, and there is a 40% stenosis of internal carotid artery. Which of the following is the most appropriate way to manage a stroke prophylaxis? Now they're talking about the secondary prevention. What is the question? In an elderly lady, I'll write down what are the important points we have seen. Previous history of stroke. All right. Next, what we saw? 40% carotid stenosis. What is the next thing you will give? Warfarin is not indicated here. All of you know, I believe. Carotid endarterectomy, it should be more than 90% or more than 75% with severe symptoms. Otherwise, no. Aspirin, you won't prefer here typically. Rivaroxaban, all your 10A inhibitors, the SABANs are not indicated here, but the clopidogrel is the prophylactic agent of choice in this case. Now my next question, what is the mechanism of action of clopidogrel? Who is going to type? What is the mechanism of action of clopidogrel? Because this question can be twisted, all right? This question can be twisted and asked in an entirely different way. Which of the following is the mechanism of action of that? Of the drug you are going to give. So, ADP antagonist. Very good, very good. Beautiful. All right. Shall we go to the next? 82-year-old man presents to cardiology with syncopal attacks. His general practitioner is treating this gentleman with worsening hypertensive heart failure. He takes furosemide 80 milligram, ramipril 10 milligram, and a small dose of spironolactone is added to him. He presented with an angina attack on the emergency department, suffering chest pain. So he's having a chest pain, he's having a syncope, and you are seeing the blood pressure is around 165. All right. There is a systolic murmur loudest in the aortic area. No ejection click. He has basilar crackles on auscultation. All right. So chest X-ray shows bibasal infiltrates, fluids in cardiomegaly. All right. His pulse is 92 beats per minute. Okay. There is nothing else mentioned. Creatinine is obviously high. So what is the difference? What are the diagnoses? All right. So what are the problems? He is having chest pain. He is having syncope. He is having hypertension, tachycardia. What is the diagnosis? Subacute bacterial endocarditis. No history of fever or any peripheral markers, so we can rule it out. No history of joint pain, chorea, or anything as such. Rheumatic fever ruled out. Tricuspid, malformed tricuspid aortic valve. Bicuspid aortic valve. Yes, bicuspid aortic valve will lead to what? Where you will find bicuspid aortic valve? That's the next question. Come on, we will learn everything. Everything we should learn and go here. Bicuspid aortic valve. Yes, Turners, Marfan's, all these things. You will find bicuspid aortic valve. All right. That's not the answer. In Marfan's, more of aortic root dilatation will be there. So, the senile degenerative aortic stenosis. All right, senile degenerative aortic stenosis. Now there will be another question coming in elderly geriatrics, which I have to teach you. What is the difference between aortic stenosis versus aortic sclerosis? What is the difference? Both will be occurring in old age, of course, not in the young patients. Right? Young aortic stenosis, we do have people like Williams syndrome, supravalvular aortic stenosis, right? So what is the first difference is, here in the aortic stenosis, there will be slow rising pulse. It is called pulsus parvus et tardus. Fancy name. Here you won't find that. Here you won't find that. Okay. Here the ejection systolic murmur will radiate to carotids. Very good, Dr. Mack. Here there won't be carotid radiation. Here there can be signs of heart failure. Here there won't be any signs of heart failure. Here the apex can be undisplaced where that can be. So these are some of the common findings. So this is a case of aortic valve stenosis. I hope all of you got it. I hope all of you are clear. And there is no doubt in that. 75-year-old women presents with increasingly low mood. She's having continuously low mood for the past 6 weeks. She has gotten into serious problem with the debt, which her daughter settled for her, but still has a fixed belief that the creditors are chasing. So she's having some form of paranoia. Additionally, she is off her food. eating only very small, and she wakes up early hours of the morning. I told you during my psychiatry class, I don't know whether now I'll take your psychiatry, and sure, I may be coming only for one more class for you also. In case of this particular early morning awakening, I used to tell something to you all. If a patient is complaining that he is awakening in early morning, it's very, very, very good to wake up early morning, and especially you wake up early morning and you do the prayer to your creator. That's a beautiful thing. You wake up and you bow down before your creator in the early morning. That's the best thing you can do. But of course, sometimes people not for prayer and they're awakening up for early morning for no obvious reason is a character of very good Dr. Osama. That's called depression. Straightforward. You don't need to look at multitude of options and confuse yourself. Early morning awakening is equal to depression. Where is it? Done. You don't need to worry about anything. Early morning awakening, most likely patient is going to have depression without any doubt. Without any doubt. All right. Next, 67-year-old man is admitted to the emergency department, suffered a sudden collapse with left-sided hemiparesis. There is a past history of hypertension for which he takes ramipril, amlodipine, type 2 diabetes, and metformin, and glycoside. Oh my God, a lot of medications. He has a left-sided hemiparesis. You notice there is a tongue deviation to the right and nystagmus on looking at the left. And there is a right-sided Horner syndrome. Blood pressure is high, pulse rate is high, and the chest is clear. What is going on? First, tell me the diagnosis. What is the diagnosis here? Right-sided Horner's. Left-sided hemiparesis. Doctor, will there be a weakness in lateral medullary syndrome or not? You have to tell me that answer. Will there be a weakness in lateral medullary syndrome? Yes or no? Will there be a weakness or will there be ataxia? Need to tell me. Is there going to be weakness or is there going to be ataxia? Which is predominant? How Wallenberg syndrome will present? What will be most predominant? Any stroke will produce weakness. Will there be a weakness like how an MCA or ACA territory stroke? Or will there be more of ataxia which will predominant? Ataxia will be more predominant here. All right. So where do you localize? In general, tell me, where do you localize the lesion? Just tell me. Okay. I don't want to treat you more into neurological spectrum. Just see here. There is hemisphere, there is brainstem, there is cerebellum. Three things. First, tell me where. Is it in the hemisphere, or is it in the brainstem, or is it in the cerebellum? We will rule out what is not there. Will there be a is this a hemispheric stroke? First, what kind of hemiplegia is this? One side there is an ocular involvement, contralateral side there is a weakness. This is called a crossed pattern. Am I right? This is called crossed pattern hemiplegia. Eye findings on one side, weakness on the opposite side. If you are finding this thing, it's all going to be your brainstem lesion. All right. So it's not hemisphere. Hemisphere is ruled out. Will a cerebellar syndrome present like that? How they will present? They will present with ataxia, incoordination, slurred speech, So cerebellum is ruled out. Now we know it's from brainstem. Now, is it the right brainstem or left brainstem? How to diagnose? Anybody? How to know whether it's a right brainstem lesion or it's a left brainstem lesion? How will you know? Come on, all of you can answer. Is it a left brainstem or is it right brainstem? The site of the Horner syndrome is the site of the lesion, right? Where is the Horner's? There is the lesion. Just to remember this easy thing. On the bedside, you will know. This kind of weakness, on the bedside, you will know. Which side the eyelid droops? End of the story. Right brainstem. Okay. Yes, always remember the side of the Horner syndrome. That's the easiest way we remember in stroke medicine. We just go see the Horners, we will know what it is. Obviously, you need to localize the lesion. That's a different issue. The bedside, quick thing for MCQ, side of the Horner syndrome is the side of the lesion in brainstem, always. Okay, this rule of 4 and all not needed for you. Now coming to the next question. 71-year-old man is coming to you. He is admitted to the emergency department. Okay, in ambulance after collapsing at home. His wife is recounting something that this particular gentleman has severe occipital headache, neck stiffness. He's telling it's the worst headache of his life with a high blood pressure and GCS of 5. High blood pressure and GCS of 5. So what is happening here? What is happening here? While you are preparing, listen here, the question is not over. There's subarachnoid hemorrhage, whatever is on. While you are preparing to intubate him, the BP suddenly goes and the pulse slows. What is it called? What is it called? And see here, what is it called? And bicarbonate is going little low. What is it? Excellent. This is Cushing's reflex. Fantastic. It's called Cushing's reflex. So what are the components? Wide pulse pressure with increasing systolic blood pressure and decreasing diastolic blood pressure. Irregular respiration. Bradycardia. It's Cushing's reflex. Okay. Why Cushing's reflex occurs? It's a natural protective mechanism. Okay. It's a natural protective mechanism. It's a natural protective mechanism of increased intracranial pressure. Whenever the intracranial pressure is going to be increased, the natural protective response is a Cushing's reflex. So what is the answer? What would have caused an increased intracranial pressure in a patient you are suspecting of subarachnoid hemorrhage? Come on, want your answer? What in the above would have caused? Extension of stroke? Obviously not. Unstable angina? Definitely not. Myocardial infarction? Definitely not. So you are left with C or D. Tonsillar herniation, transcalvarial herniation. Which is the most common complication of a subarachnoid hemorrhage? Is it tonsillar herniation or a transcalvarial herniation? What is it? Okay, the answer is C. Tonsillar herniation. All right, it's tonsillar herniation. All right, we'll work out one MCQ here and we will stop, and I will definitely spend 10 minutes to clear your any doubts you have in MRCP. I'm ready to interact with you all. Okay. 84-year-old woman brought to the ED, her daughter after she found to be suffering from an offensive vaginal discharge. Oh my God, like 84-year-old lady with an offensive vaginal discharge. She has some memory loss. See, MMSE is only 8. And swabs are consistent with gonorrhea. Just pay careful attention. Sir, 84-year-old female with gonorrhea. What is the next thing you will suspect? What you will suspect? An 84-year-old lady is there and you are finding gonorrhea in a 84-year-old lady. What you will be most worried about? Excellent, Dr. Razia. You will be worried more about any sexual abuse. All right. Any elderly or any sexual abuse is something you are going to be most worried about. Obviously, gonorrhea is an STD. Good doctor. It's an STD, but you will be worried mostly whether is there any sexual abuse is involved in that. So what is the next thing you will be doing here? See the options. Informal inquiry at the nursing home. Will you become a Sherlock Holmes? Put your rounded hat and go there, put a long coat and go and do your own investigation. Or you gonna initiate a contact tracing on your own? Or you gonna call her daughter and tell, oh my God, your mother is having gonorrhea, what's happening in your home? You have any idea? Or you will be like, why there is a headache for me? Just leave me, let me just write some medication and send her off. Or you're gonna call the police. Or you're gonna call the police. A, B, C, D, E, what you are going to do? You cannot initiate contact tracing on your own. You cannot play Sherlock Holmes. You cannot leave it just like that because they will come and catch you tomorrow, because everything is meticulously documented in the United Kingdom. All right. Every single thing is meticulously documented. You cannot just like that do whatever you want and go and live your life. No, you have to inform the doctor. Yes, doctor. I mean, like, yes, you have to. Not right now, but at one point of time. But the next important thing you have to do, sound of the police, call the police will come now, and definitely the nursing home or doctor, whoever it is, they are going to conduct an extensive inquiry because this is something serious. This is abuse. Abuse of the vulnerable. Elderly lady with dementia is a vulnerable lady. She cannot move, she cannot speak much. Maybe we don't even know what kind of comorbidities she is having right now. It's an abuse. So, such abuse, what is the next thing you need to do? You are going to call the police, right? The next thing you are going to do is you are going to call the police. All right, clear? Any doubt? Any doubt, anyone on this? Fair enough. One more question we will work out. All right, because we started 5 minutes late, let us compensate that. 82-year-old gentleman presents to the emergency. The option is contact protection services. Yes, protection police is one of the protection services. Okay, but if the police is mentioned, you have to go for police. Police is mentioned, police. That's it. Police is mentioned, it's police. You have to go for police. End of the story. You are not going to go for anybody else. Only police. Clear, doctor? 82-year-old gentleman presents to the ED with shortness of breath, palpitations, which have been present for the last 2 to 3 hours. No previous history of breathing problems. What's happening? He's on amlodipine for hypertension. Blood pressure is 80/70. Heart rate is 140 beats per minute, irregular, so he's on AFib. And there is crackles. Just imagine this patient is right in front of you and you are the acute medicine registrar. What you are going to do? I want you to answer without seeing anything. All right, because this can come even as your NHS interview question. If I'm going to sit there in the panel, I'm going to ask you that. Dear doctor, you're getting an 82-year-old man or lady, whoever it is. The blood pressure is dropping. See, I'm not asking about diagnosis. All right, the blood pressure is dropping. Already on irregular rhythm, atrial fibrillation, there is crackles. What is the next thing you want to do immediately? Come on. Come on. What is the next thing you need to do? What is the next best thing in this particular patient? No, 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 not oxygen. No, no. NORAD in an atrial fibrillation. My God, no, not amiodarone. No, doctor. What is the problem here? Here the blood pressure is dropping. What you will do? ALS protocol. You go for DC cardioversion. Do you need an option for this? Do you actually need an option for this, doctors? No. ACLS is American. ALS is UK. ILS and ALS. Advanced life support. In American, advanced cardiac life support. American BLS, basic life support. Here, ILS, immediate life support. All right. If you're planning to come to UK, you can attend one of these courses. That's happening all around. Because UK, they approve European and Australasian courses. They don't approve American courses. Otherwise, what happens is they will make you to go ahead and learn there in the UK. They will pay for you, but again, you have to take care of your travel and stay, everything. And passing this ALS and ILS in UK is slightly difficult. Even the okay, you don't do that. And for ventricular fibrillation, all right, ventricular fibrillation. If you're interested, I will tell you what to do for a ventricular fibrillation. Okay, just a second, just erase it. Ventricular fibrillation, what you are going to do. So this question, first we will come here, atrial fibrillation. So the answer is synchronized DC cardioversion. So it is going to be your synchronized DC cardioversion is the answer. All right, synchronized DC cardioversion. All right, just a minute. I'll write here an adult tachycardia algorithm, what you will be doing quickly. Yes. Okay. All right. This will answer all the doubt. Ventricular tachycardia, what we will do. Okay. First, stabilize, especially the airway. Check the breathing. If the breathing assistance is needed, you give. Then give O2 only if the patient is hypoxemic. Otherwise, don't give oxygen unnecessarily. All right. Then immediately connect to cardiac monitor. Then secure IV access. Check a 12 lead ECG if possible. Look for a couple of things here. Okay. If there is anything like a I'll just erase this and because I don't want anyone to go with any kind of doubt here in my session or not satisfied with anything. Hypotension, altered mental state, signs of shock, ischemic heart disease, or any acute heart failure, check. If it is yes, okay, you have to go for DC cardioversion. All right. Then for ventricular, suppose here it's a wide QRS tachycardia. That is more than or equal to 0.12 second. If it's yes, what are the first things you need to do? Adenosine. Sorry, if there is a wide QRS count, okay. If it is a regular, you can give adenosine. If it is a wide QRS tachycardia, then the best thing you can go for in case of a wide QRS tachycardia is going to be your, what drug you will be starting? What is the drug? What drug you will be starting? Anyone? One answer. Anybody? Yes. You can go for amiodarone. No, amiodarone. And still, if the rhythm is not going up, even in case of VTVF, yes, you can defibrillate. After every defibrillation, you have to give CPR for 2 minutes. All right, CPR for 2 minutes. If still not responding, then epinephrine, I'm talking about here VTR, epinephrine, amiodarone, and look for ROSC. What is ROSC? What is ROSC? What is ROSC, doctors? Anyone? What is ROSC? Come on. Nobody wants to answer what is ROSC. Yes. Return of spontaneous circulation. All right. ROSC means return of spontaneous circulation. All of you got it? All of you clear? Any doubts? Any doubts in this? Please let me know any doubts in this. We shouldn't walk out with doubts. Clear? Crystal clear? Okay. Any doubts in this? Please let me know right away because I won't be here. Yes, you can, Dr. Abhishek. You can use. Yes, you can use. There are a lot of guidelines in UK they are using. Okay. They're using a lot of guidelines. First thing, as soon as you connect, you are going to find only one thing. Once you connect to the halter, is it a shockable or non-shockable rhythm? All right. First thing is it a shockable or non-shockable rhythm? And what are the non-shockable rhythms? What are the non-shockable rhythms? Can you all give me three? One example. What are the non-shockable rhythms? Asystole, good pulseless electrical activity. What else is there? Anything else? Nothing. Sometimes no bits can go for. So these are the shockable rhythms. So shockable rhythms, you can go for a shock. And non-shockable rhythms like asystole, pulseless electrical activity, VTVF are non-shockable, you can shock. VTVF and all, you can very well shock. There is no doubt in that. You can shock. That's not shockable, non-shockable rhythms. All right, that's not non-shockable rhythms. Any doubt in this? Any more doubt? Any doubt? Anyone? Anyone? You want narrow complex tachycardia rhythm? You want? Okay. Let us write here. Yes. Yes, 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 I will do. Okay. What is a narrow complex tachycardia? All right. First, see the same thing. Like I said, your A, B, C, D, everything you are doing, you give O2 only if saturations are decreased. Otherwise, unnecessarily, you don't give any form of oxygen. First thing, learn when to give a saturation, when to give it, and when not to give. Okay. Check first, it's a regular, irregular. Okay, regular rhythm, what are the things you can give? First thing, you have to try vagal maneuvers. If it is ineffective, adenosine. Then monitor. If it is still ineffective, you can give verapamil beta blocker. Still ineffective, you can go for shock or other things. Irregular. Okay, irregular. If it is an irregular, then most probably what rhythm? It's going to be an atrial fibrillation. Okay. In atrial fibrillation, immediately you control the rate with the beta blocker typically, and consider digoxin in case of heart failure plus anticoagulation. This is some short algorithm for you all. Okay. Short algorithm for you all. I hope you got it. Okay. If you want a broader algorithm from UK ACLS, I think here we can write. We can write here. I would rather have a separate session on that for everything, including hyperthermia and everything. Maybe we can have a free session on that. Okay. Definitely I'll have a free session on that. Anything else, doctors? Any doubts? Anybody? Any doubts? Anything you want to ask, you ask me. I'm free now. It's already, we are running 15 minutes away from the scheduled time. Any doubts, anybody on MRCP or anything, please feel free to ask me. I'm ready to answer. I won't leave without answering you. All are clear? No doubts? Is there a weightage for geriatric medicine? Geriatric medicine will come around 5 to 7 MCQs. That's the weightage. 5 to 7 MCQs. Solid, it will come. 5 MCQs definitely it will come. 100%. 5 MCQs, sure shot. Then, anybody else? Any doubt? Please feel free to ask me. I'm here to talk to you. No doubts? So last class we were discussing about audit, how to do audit. Doctor, first to finish part one, an audit simple way to do this, just go to your hospital and talk to your consultant or your ethical committee and just ask for some samples. For example, you can do simple audits like somebody you are putting the patients regularly. For example, you are going to put a set of patients on nebivolol and try just to see what are the symptoms before nebivolol and what happens after nebivolol, how the blood pressure is improved and what are the symptoms has been improved. That's audit. That's it. Yes, doctor. TIA, TIA we will separately see, doctor. TIA we will have a separate algorithm. We will see. Definitely we will see TIA. Okay. In neurology, mostly I will take TIA. All right. Any doubts? No doubts. Then I'll close the session, doctors. Thank you so much for coming up all the way. Don't know when I'm gonna see you. If there is possibility, I will come and take neurology for you all. Okay. Otherwise, read and learn with other mentors and other team in MedExam expert. They will guide you. I wish you everyone the very best. Any doubts, feel free to text me. I may not reply earlier, even if I see the message, I'll definitely reply you. Okay, please do leave a feedback in the respective group you are come from about the lecture you had attended. I'll be very, very much pleased and honored with your feedback. And if you are here around anywhere in both Glasgow or India, you want to attend our free clinical sessions, you are most welcome to walk into our clinical sessions and attend. Okay, my clinical sessions are always free. You can come, your food is free, your attendance is free, everything is free. You can watch me on YouTube everywhere. Our free clinical sessions, if you are interested in clinics for PACES examination, you can walk in straight away to any part. Okay, you can find our schedules. All right, thank you so much. Thank you so much, everyone. And please leave your feedbacks. That's my only request. All right, thank you. Good day. God bless you. Have a blessed evening. Bye bye. See you.